There is something happening inside the bodies of millions of people over 60 that their doctors never sat down and explained clearly. Every single day they take their pills, the same ones prescribed months or years ago. And they assume that because a doctor gave them those pills are still safe. That assumption is costing people their lives. What most people do not realize is that a medication that was perfectly reasonable for you at 50 can become a genuine cardiovascular threat by the time you reach 65. And the reason has nothing to do with the drug itself changing. It has everything to do with what your body quietly stopped doing. Today we are going to talk about 5 specific medication categories, drugs that are extraordinarily common, drugs that sit in bathroom cabinets across the country, and we are going to walk through exactly how each one interacts with the aging cardiovascular system in a way that raises stroke risk. We will also give you one clear practical action step for each one, something specific you can bring to your doctor. My name is Dr. Marcus Evans. I am a medical doctor and physician, and this channel is where I break down what is actually happening inside your body. The mechanisms, the biology, the things that get glossed over in a 10-minute appointment, so that you can walk into your next doctor's visit with real questions and real understanding. If that is the kind of content that matters to you, take a second and subscribe. It helps more people find this information when they need it most. Now let us start at the foundation, because without understanding this first piece, nothing else we cover today will fully make sense. After 60, your body processes medication differently, significantly differently. And this is not a subtle shift. It is a biological reality that changes how every drug behaves once it enters your system. Here is what is happening. Your kidneys and liver are the 2 primary systems your body uses to filter, metabolize, and clear drugs from your bloodstream. Think of them as a 2-stage processing plant. The liver breaks the drug down into its components, and the kidneys flush those components out through your urine. That process, that clearance cycle, is what determines how long a drug stays active in your blood and at what concentration. By the time a person reaches their mid-60s, kidney filtration rates have typically declined by 30 to 40% compared to their younger years. The liver follows a similar pattern: slower enzyme activity, reduced blood flow to the organ, less efficient processing overall. This is not a disease, it is normal biological aging, but the consequence is serious. Drugs stay in your system longer, they accumulate at higher concentrations, and they exert more pressure on your cardiovascular system than they did when your clearance systems were functioning at full capacity. Now here is why that matters specifically for stroke. Stroke is a blood flow event. It happens either because a clot blocks circulation to part of the brain, or because a blood vessel ruptures under excessive pressure. Both of those scenarios, clot formation and elevated blood pressure, are directly influenced by the medications you take. And when those medications linger in your bloodstream longer than they are supposed to, the margin for error disappears. One more thing before we move into the 5 categories. There is a concept called the drug half-life. The amount of time it takes for your body to reduce the drug's concentration in your blood by half. When your kidney and liver functions slow down, that half-life extends. A drug that used to clear your system in 8 hours now takes 12. A drug designed to have a mild daily effect now has a compounding effect because it never fully clears before the next dose arrives. That is the foundation. That is the mechanism that connects aging physiology to elevated stroke risk. And now that you understand it, the 5 medications we are about to cover will make a great deal more sense. The first category is one of the most widely used over-the-counter drug classes in the world: NSAIDs, non-steroidal anti-inflammatory drugs. That includes ibuprofen, sold as Advil and Motrin, and naproxen, sold as Aleve. These are the pills people take for a sore back, a stiff knee, a tension headache. They are cheap, they are everywhere, and because you can buy them without a prescription, there is an assumption baked into their availability that they must be harmless. They are not harmless, not after 60, not taken regularly. Here is the mechanism. NSAIDs work by blocking a family of enzymes called SOC enzymes, cyclooxygenase enzymes, which are responsible for producing prostaglandins, the compounds that drive inflammation and pain. That is the part people understand. That is why the pain goes away. But those same COX enzymes also regulate something inside your blood vessels. They help maintain a balance between 2 competing forces, one that promotes clotting and one that prevents it. When NSAIDs block those enzymes systemically, they shift that balance. They tend to promote clotting while simultaneously causing sodium and water retention, which raises blood pressure directly. In a younger person with fully functional kidneys, these effects are transient. The drug clears, the balance resets. But in a person over 60 with reduced renal clearance, the drug lingers. The sodium retention compounds, blood pressure climbs, And sustained elevated blood pressure is one of the most significant modifiable risk factors for stroke in existence. Studies published in cardiology literature have demonstrated that regular NSAID use in older adults is associated with a measurable increase in cardiovascular events, including stroke, within weeks of starting consistent use. The risk is dose-dependent and duration-dependent, but the threshold is lower than most people expect. Your action step for NSAIDs is this. At your next appointment, ask your doctor whether acetaminophen, Tylenol, can replace your regular ibuprofen or naproxen use. Acetaminophen works through a different mechanism, does not affect Salcox enzymes the same way, and does not carry the same cardiovascular burden for the aging heart and blood vessels. It is not the right fit for every situation, but it is a conversation worth having. Now, the second medication category is one that almost nobody flags as a cardiovascular concern. And that is precisely why it is so dangerous. Decongestants, specifically pseudoephedrine, the active ingredient in many cold and sinus medications, Sudafed being the most well-known. It is sold behind pharmacy counters in most states, not because it is a controlled substance in the traditional sense, but because of its chemical precursor status. People assume that means it is reasonably safe. That assumption is not correct in the context of older cardiovascular systems. Here is what pseudoephedrine actually does in the body. It is a sympathomimetic drug, meaning it mimics the effects of your sympathetic nervous system, the branch of your nervous system responsible for the fight-or-flight response. When you take pseudoephedrine, it signals your blood vessels to constrict. It shrinks the swollen nasal tissue that is causing the congestion. That is the effect people are after. But it does not selectively constrict only nasal blood vessels. It constricts blood vessels throughout the body. And that systemic constriction drives blood pressure up, sometimes sharply and rapidly, in a way that puts direct mechanical stress on the arterial walls feeding the brain. For a person with pre-existing hypertension, arterial stiffness, or undiagnosed cardiovascular changes, all of which become significantly more common after 60, a single dose of pseudoephedrine can create a blood pressure spike that pushes into genuinely dangerous territory. We are not talking about a gradual rise over weeks. We are talking about an acute spike within an hour of taking the pill. Your action step here is straightforward. Before taking any decongestant, check your blood pressure. If it is already elevated, do not take pseudoephedrine without speaking to your doctor first. Ask your doctor or pharmacist about antihistamine-based alternatives, saline nasal rinses, or steroid nasal sprays for sinus congestion instead. These approaches do not carry the vasoconstricting cardiovascular load. And here is something worth sitting with before we continue. Both of these first two medications are ones people take casually, without thinking, without checking interactions, without considering what 63-year-old kidneys and a slightly stiffened arterial system do with the compound they just swallowed. The next three categories we are about to cover involve prescription medication, drugs your doctor deliberately put you on, and they carry a different kind of complexity. The third category involves a class of antidepressants that have become among the most prescribed medications in the world over the last 3 decades. Selective serotonin reuptake inhibitors, SSRIs. Medications like sertraline, escitalopram, fluoxetine, and paroxetine. Now this one requires careful framing, because the last thing anyone should take from this is that antidepressants are universally dangerous or that people should stop taking them. That is not the message. The message is that SSRIs carry a specific and frequently overlooked effect on the blood that becomes more significant as the body ages. Here is the mechanism. Serotonin does not only operate in the brain, it is also present in platelets, the blood cells responsible for clotting. Platelets use serotonin as part of the signaling process that triggers clotting at an injury site. SSRIs work by reducing the reuptake of serotonin back into cells, which depletes the serotonin stored inside platelets. Over time, platelets on SSRIs have reduced clotting capacity. Now, in some context, reduced clotting is actually desirable. It is the same principle behind aspirin therapy for heart disease. But in the context of an aging brain with small vessel disease, or in combination with other medications that also affect bleeding, this platelet effect can become a liability. Research has shown that older adults on SSRIs have a modestly elevated risk of hemorrhagic stroke, the kind of stroke caused by bleeding in the brain rather than a clot. That risk increases significantly when SSRIs are combined with NSAIDs, aspirin, or blood thinners. The individual risks stack together. Your action step for SSRIs is to have an explicit conversation with your prescribing doctor about which other medications you are taking simultaneously. Ask specifically whether any combination you are currently on increases your bleeding risk. Ask whether your current dose is still appropriate given any changes to your kidney or liver function since the medication was first prescribed. These are not confrontational questions. They are exactly the kind of review that should happen routinely, and often does not. The fourth category is loop diuretics. The most common is furosemide, sold as Lasix. These are powerful drugs prescribed for fluid retention, heart failure, and certain forms of high blood pressure. They work by telling the kidneys to excrete more water and sodium through urine, essentially forcing excess fluid out of the body. The mechanism that creates stroke risk here is dehydration-driven blood thickening. When furosemide pulls fluid out of the body, it reduces blood volume. In controlled amounts and with adequate fluid intake, that is the intended effect, less fluid pressure on the heart. But in an older adult who may not feel thirst as acutely as they once did, because thirst perception also diminishes with age, the fluid loss can go too far. Blood volume drops, blood viscosity increases, thicker blood clots more readily. At the same time, furosemide also depletes potassium. Low potassium, a condition called hypokalemia, disrupts the electrical signaling in the heart. It can cause arrhythmias, which are dangerous irregular heartbeats. And atrial fibrillation, one of the most common arrhythmias, is itself a significant and independent risk factor for stroke because it allows blood to pool and clot inside the heart's chambers. Your action step here is twofold. First, if you are on furosemide, ask your doctor how much fluid you should be drinking daily to offset the diuretic effect. Get a specific number, not a general recommendation. Second, ask whether your potassium levels are being monitored regularly. Potassium-sparing diuretics or potassium supplementation may already be part of your regimen, but if it has been a while since those levels were checked, request a blood panel. Now, the fifth category is arguably the most nuanced because it is not about a single drug. It is about a dangerous combination pattern that affects a significant percentage of older adults managing hypertension. Certain blood pressure drug combinations, specifically certain pairings of ACE inhibitors or ARBs with calcium channel blockers and diuretics, are prescribed together to achieve better pressure control than any one drug can deliver alone. That is medically sound logic. But the problem arises when those combinations are not regularly reassessed as the body ages and cardiovascular physiology continues to shift. Here is what can happen. An older adult's blood pressure regulation becomes less responsive and less dynamic with age. The arterial walls stiffen. The autonomic nervous system, which helps regulate blood pressure moment to moment, becomes slower. In this context, a combination of 3 antihypertensive agents can occasionally drive blood pressure lower than is actually safe. Blood pressure that is too low, a condition called hypotension, reduces blood flow to the brain. When the brain is not receiving adequate perfusion, the risk of an ischemic event increases. There is also a well-documented phenomenon called orthostatic hypotension, which is a sudden drop in blood pressure upon standing up. In older adults on multiple antihypertensives, this sudden drop can be severe enough to cause momentary loss of blood flow to the brain, and in some cases, that is all it takes. Your action step for blood pressure combinations is to ask your doctor for a home blood pressure monitoring review. Track your numbers at different times of day and in different positions, seated and standing. If you notice significant drops upon standing, or if your readings are consistently running lower than your target range, bring those logs to your appointment. That data is far more useful than a single in-office reading taken once every few months. Before we close, there is one more layer to this that does not get discussed enough. The early warning signs that a medication may be exerting cardiovascular stress, signs that can appear before anything catastrophic happens if you know what you are looking for. The challenge is that many of these signs are easy to dismiss because they feel manageable. They feel like getting older. And that is exactly what makes them easy to miss. Persistent headaches, particularly ones that feel different in character or location from your normal headaches, can reflect blood pressure changes driven by medication. Not every headache is a warning, but a pattern of headaches that emerged or intensified after starting or increasing a medication is worth noting and reporting. Unusual fatigue or cognitive fog, especially in the hours after taking a dose, can reflect that a drug is staying in your system longer than intended and exerting a dampening effect on brain circulation. Again, this is easy to write off as age. It is worth flagging instead. Swelling in the lower legs and ankles, particularly if it appears asymmetrically, can signal that fluid regulation is being disrupted. Loop diuretics that are either underdosing or overdosing relative to current kidney function can produce this. And perhaps the most actionable warning sign of all, any sudden episode of visual disturbance, unusual weakness in one arm or one side of the face, a speech difficulty, or a feeling of confusion that passes within minutes. These transient neurological events, often called TIAs or transient ischemic attacks, are not merely a strange few minutes. They are a biological alarm. They are the body signaling that something in the brain's blood supply just came very close to failing. Anyone over 60 experiencing one of these episodes, even briefly, even once, needs to seek medical evaluation the same day, not the next morning. The same day. Now let us bring everything together, because this is the point where the picture becomes clear. Your body after 60 is not the same machine it was at 40. The systems that metabolize drugs have slowed. The blood vessels are stiffer and less elastic. The margin for error in the cardiovascular system is narrower. And the medications you are taking, medications that may have been calibrated for a younger version of your physiology, may no longer be interacting with your body the way they were designed to. This does not mean your medications are wrong. It does not mean your doctor made a mistake. What it means is that medication management in older adults is not a set-it-and-forget-it process. It requires regular reassessment of your health and medications. It requires your active participation. And it requires you to walk into that appointment with specific, informed questions, not just a general sense that something might be off. So here is your complete action list. 1 step per medication category. After 60, certain common medications can increase your stroke risk. Here is how to have those vital conversations with your doctor. For NSAIDs, ask whether acetaminophen can replace regular ibuprofen or naproxen use given your current cardiovascular profile. For decongestants, check your blood pressure before taking pseudoephedrine and ask for non-vasoconstricting alternatives for sinus congestion. For SSRIs, ask your doctor to review the full list of medications you are taking alongside your antidepressant and assess whether any combination increases bleeding risk. For loop diuretics, request a specific daily fluid intake target and ask for a current potassium level check if it has been more than a few months. For blood pressure combinations, begin home blood pressure monitoring at different times of day and in different positions, and bring that data to your next appointment. These are not difficult conversations. They are the conversations that protect you. The research is consistent on this point. Older adults who engage actively in medication reviews, who come prepared, who ask specific questions, who flag changes in how their body feels since a prescription was written, have measurably better cardiovascular outcomes than those who do not. Information is not enough on its own. You have to use it. If this video gave you something useful, a question you did not know to ask, a mechanism you did not know existed, a warning sign you now know to take seriously, then share it with someone you care about. Someone over 60 with a cabinet full of prescriptions who has never had this conversation. They deserve to know what you now know. And if you want to keep going deeper into what the aging body actually needs to stay well, the foods, the habits, the hidden risks, and the overlooked solutions, subscribe to this channel. This is the work we do here. Every video, every time. None of this means these medications are inherently dangerous for people over 60. For most people, most of the time, they're managed fine. But there are 5 specific drug categories where the interaction between aging physiology and the drug's own mechanism of action creates a meaningful, underappreciated elevation in stroke risk. If you're over 60 and taking any of them, or living with someone who is, you need to know exactly what they are and what to do about it. Why this matters more right now than it did 10 years ago. The average American over 65 takes between 4 and 5 prescription medications daily. Add over-the-counter drugs, pain relievers, cold medicines, sleep aids, and that number climbs. Each drug was likely evaluated and prescribed on its own merits at a specific point in time for a specific reason. What rarely happens is a systematic look at all of them together, through the lens of how an aging body is actually metabolizing them today. That's not negligence on anyone's part. It's a structural gap in how medicine is practiced. Specialists manage their conditions. Primary care physicians manage the overall picture, but in limited time with limited bandwidth for medication reconciliation. The result is that millions of people over 60 are carrying drug combinations that made sense when they were assembled, but haven't been formally re-examined as kidney function declined, as cardiovascular risk increased, as new medications were added on top of old ones. You are the person best positioned to close that gap. Not because you should be doing your doctor's job, but because you are the one person who shows up to every appointment and carries the full picture of what you're taking. The 5 medication categories coming up are specific. The mechanisms are real. And for each one, there's a concrete action step, not vague advice to talk to your doctor, but a specific question to bring in, worded in a way that opens the right conversation. Pay attention to the one that sounds most familiar.